Thank you so much for this opportunity. And I think Dr. Raja and my previous speakers have set the ground. And uh, basically, when we talk about lung cancer, most of the people will be asking a question like, now it is more, as you all aware that most of the time the lung cancer patients are also diagnosed at an advanced stage. So most of them will be asking, in this stage, is there any benefit if we make them to quit, or should we leave it like that, or is there any benefit that we put pressure on them to quit the habit? uh, of course, the benefit is multiple, and every aspect. If you look at, the benefits of quitting, Dr. Raja also presented, and the same benefits are added to the lung cancer patients also. But here will be the problem is when a patient comes to a cancer hospital and meet a clinician, they will be coming with a lot of problems, a lot of symptoms, and the family also will be putting a pressure on them, that and the guilt, they will develop guilt over the patient, like, okay, uh, why did you get this cancer? Only because of smoking you got this cancer. So at least now you quit. Even the people, the family members who have not put pressure before, will start putting pressure on them when they are diagnosed with the cancer. So this become an additional pressure on the patient while suffering with the symptoms associated with lung cancer. Making an effort to quit will be an additional burden on the patient themselves. And for a clinician, particularly the lung cancer specialist, the oncologist, they have a challenge whether to concentrate on the lung cancer treatment, or should we be focusing so much on the tobacco smoking cessation, because smoking cessation itself is a separate treatment process. And so much efforts and treatment burden is there on treating the disease itself. So they have to play a dual role in this context. So where will we give the priority? Like, should we be concentrating and spending our time on smoking cessation, or will we be spending more time on treating the disease itself? And here the family will be developing a guilt, like, stop smoking, all everything happened because of smoking only. That burden will push, and all sorts of pressure and anxiety will be there. But at the same time, the patient also will be finding it difficult to cope up with the disease and its related symptoms. So here in this context, how will we go about it? And will there be a benefit in making effort, or simultaneously trying for smoking cessation also? So of course, there are benefits. Where the evidences are saying more than 40% of the lung cancer patients were diagnosed. At the time of diagnosis also, they were smoking. And some patients would be suffering with the symptoms for about 6 months to 1 year. And due to symptoms, they would have stopped smoking uh, 2 months or 1 month, or previous months they would have stopped. But most of them continue to smoke even at the time of diagnosis, and more than 80% of them continue to smoke even after the diagnosis also. So smoking cessation brings benefits in terms of improving the quality of life and in the treatment response. And there are evidences proving the smoking cessation bring additional benefits in terms of survival and quality of life. And even the people who are undergoing treatment, the surgery related complications also will be minimized if they quit even after the diagnosis. So it's not too late. And even the chemotherapy responses increases. And so every clinician parallelly, if they want to reduce the number of multiple hospitalization, and reduce the complications related to treatment, and improve the efficacy of the treatment after the treatment completion, we need to make efforts for smoking cessation. So it has to be integrated into the oncology treatment itself. But at the Cancer Institute, we had the privilege of having a separate department for smoking cessation. And as soon as the patients are diagnosed, and when they are found out, they are smoking habit, and the family members themselves will come and report to the doctors, and they are immediately referred to a smoking cessation clinic. And initially, in the initial days, when when the patient was referred to a smoking cessation clinic, they do not come. They do not come and attend because in the busy hospital, and they have been undergoing multiple investigations and schedule appointments with the doctors and other things. They will not be able to. Even the family members will be finding it difficult to schedule an appointment with a smoking cessation expert when it is functioning as a separate department. But they, and also the clinical oncologist, they will be forgetting to follow it up. Whether you have gone, I referred you, did you go and attend the cessation clinic? So these follow-up also will not be there because they will be busy with their own treatment process and other things. But because there is no insistence from the oncology team, and they once the referral is made, if they don't make an attempt to go there, or once they make an attempt and they see, okay, there are a lot of there is no active any treatment, or they don't give immediately any medicines, they don't find any reason going there, so they just give up. But now later what we have done is, like we have integrated that into the, now I'm at present, I'm not at the Cancer Institute. I moved to a rural setting in a Nellai Cancer Care Center. But still, I'm just trying to, because of my previous experience with the Cancer Institute, I would like to elaborate more on the Cancer Institute setting now. So what they do, they have given access in the MedMantra, in the in the computer itself, whether the patient has gone to the uh, smoking cessation expert, that will be reported, and what is the recommendation, whether the medication has been given, or what is the next review date, everything will be documented over there. So when a clinical oncologist see in their OPD, all these histories will come, whether they have attended, when is the next review date. So he will give an additional reminder, like, whether have you gone there, and hope you will be able to quit. I hope Pratima Murthy will be enlightening about the other part of the behavioral aspect of the smoking cessation, where, a little bit of, we continue to train the oncologist in the 5A approach and the behavioral aspects of the smoking cessation. So they also continue to make efforts in their routine OPD to advise them, to educate them that it is very important for you to quit smoking cessation, to have an efficacy in terms of the treatment also. So in that way, when the smoking cessation expert and the clinical oncologist, when they work together, the quit rate increases, and at least the attending rate, the participating rate increased in the clinical setting. Then one step ahead, what happened is, like, immediately the cessation expert talk to the oncologist, and they together make a plan for what kind of intervention will suit. Is it a first line is it smoking cessation? Only behavioral intervention is enough, or the next step, are we going to treat them with the nicotine replacement therapies, or based on the severity of the addiction, do we immediately require any medications? So these things are decided in discussion with the clinical team. So that there is a tumor board, and we encourage the tobacco cessation expert also to go and participate in the tumor board when such cases are being discussed. So together, it's a, we need to work with all the disciplines so that the efficacy of quit rate increases, and the treatment outcome is also ensured. So in terms of pharmacotherapy, I'm sure Dr. Pratima Murthy also will touch upon that. And nicotine replacement therapy is considered as the first line of therapy. And whatever the pharmacotherapy we prescribe them, it has to be accompanied with the behavioral intervention. Without behavioral intervention, in the smoking cessation, any pharmacotherapy we give, that is not going to bring the desired results. So we always advise the clinical oncologist, because they do not have time, they can refer the patients to the smoking cessation expert, or the counselor, or the social worker, or psychologist, or any paramedical staff who is sitting in the hospital. They can be trained in smoking cessation, and their help can be taken. So in a big way, the treatment will be cost effective, and the patient also can smoothly come out of the disease, and they can have improved survival rate and the quality of life. So what is very important is, one is the smoking cessation has to be integrated into the oncology setting, and it definitely brings some positive results. And if we do not have time, we can integrate an additional supportive staff who can be trained in tobacco cessation, and their help can be taken. So if there are any questions, maybe we can address that during the panel discussion. Thank you so much for the patient listening.